Welcome back to Takacs McGinnis Elder Care Law Hour, where we explore the issues that arise due to aging, chronic conditions, chronic care needs, and unexpected illness. I'm your co-host, Tim Takacs, and today we're talking about the dementias, the types of dementias, the differences among them, and the options available after diagnosis.
And I'm Barbara McGinnis, and in this segment we're going to be talking with a neuropsychologist, and it's Dr. Kristen Barclay, who is from Neuropsychology Associates of Nashville, and she's going to be talking to us about what is a neuropsychologist and how does that fit into the treatment plan. So,
and you're
welcome.
Dr. Jessica Barclay, right?
Yes.
Yeah, sorry.
Sorry.
Oh, that's all right. No problem. Dr. Barclay is right.
Yeah, Dr. Barclay is right. Okay.
Yes, neuropsychology is essentially an evaluation that answers the question of, is somebody having thinking problems or cognitive problems, and if they are, what are they from? And then what treatment recommendations can be made to help things.
Not a psychiatrist.
Not a psychiatrist. A neuropsychologist is a psychologist, so they have a doctorate in clinical psychology typically, but they also have the very important specialized fellowship training, which is usually at least a couple of years where they learn the skill set that we're talking about today.
Right. So what is a neuropsychological evaluation?
Well, it typically includes a clinical interview, which is a comprehensive gathering of somebody's history in terms of, figuring out all the different possibilities for what could be explaining the cognitive issues. And then it's testing, mostly paper and pencil testing, and possibly a couple of basic computerized tests that look at somebody's thinking skills. And so the whole thing really takes anywhere from a couple hours to the majority of a day, just depending on the person's needs and how much cognitive troubles they're having. And then once they complete the evaluation, it's a neuropsychologist's job to compare their scores to people of a similar background. That should always be at least by age, and usually it should ideally be by other factors like your educational background, your occupational background, to take out how much those things are accounting for any trouble someone's having on the testing. You don't want to compare someone that's getting older to a 20-year-old brain, because that wouldn't be very fair. So that's why it's important to take out those factors.
Right.
So how do people get to you or get to a neuropsychologist in general? Is it something they can pick up the phone, or are they referred through their neurologist?
A lot of the times they're referred through their neurologists, like Dr. Assad had sort of talked about that process of initially the neurologist goes through the possible reversible causes or does the medically related tests, and then if it's unclear, a neuropsych referral can help really clarify, what's causing what and what can we do about it. So the referral, anybody can really have a neuropsych assessment, but it's typically good to talk to a PCP or a neurologist if there's concerns over something like dementia, so those people can do the initial tests.
So what are you looking for when you're doing an evaluation?
Well, what you're looking for is, number one, if there are any major thinking problems, but number two, what are the possible causes? And while that can be something like the early indications of a dementia, it can also be what's known as secondary factors, which is mood issues like depression, stress, anxiety, chronic fatigue, not getting enough sleep. Sometimes people are on a lot of medications, and that can cause some cognitive inefficiencies that can look like something concerning, such as a dementia. And also people can have chronic pain issues, so that can be, fogging up the picture of things. So it's just important to get a good history and then put all of those testing scores together with that history to determine what's causing what.
So those evaluations help the clinical team reach a more definitive diagnosis, right? Right?
Yes.
Alzheimer's versus stroke. So or Alzheimer's versus a vascular dementia. What are you looking for?
Well, different dementias, so vascular versus Alzheimer's versus Parkinson's disease dementia versus frontotemporal dementia, they have different patterns. They have different cognitive patterns, which is what the neuropsych assessment is supposed to clarify or better understand. And then there's also different behavioral or mood sort of patterns. So it's our job to put all of those factors together and say, this is either most possibly or most probably Alzheimer's, vascular, frontotemporal, or mixed dementia, including.
Okay, so tell us a little bit more about the differences of what you actually see, what you're looking for. Alzheimer's versus frontal versus vascular. Because I think, like we talked about at the beginning of the show, is people think dementia is Alzheimer's, but it's not.
Yes, that's the most common type, but vascular is the second runner-up, and there's Lewy body dementia and frontotemporal dementia. So basically, the testing looks at different thinking skills. So that includes things like processing speed, sustained attention, short-term recall, new learning and delayed memory, or just memory skills, executive functioning, which is just a fancy term for more complicated abilities like reasoning through things and connecting the dots, making decisions, problem solving, keeping yourself well organized. And then there's certain language skills, especially in Alzheimer's disease, that are affected, like naming, or your ability to come up with something called fluency, your ability to come up with different words in the same category. So it's really, you have to get a very detailed look at somebody's cognition and the pattern across those different domains or abilities and say this is most consistent together with other aspects of their history with such and such etiology or type of dementia.
Right.
And you can also, differentiate between neurologic factors and secondary factors, which is the depression, anxiety, fatigue, medication side effects, and then that really shifts where treatment goes beyond that point in terms of what should be prioritized.
So evaluations, you said, could take a couple of hours to most of a day, depending on what all you're looking for, or how, I guess, what the person's like, what they can tolerate if they have to break it up in little things. We've all seen the clock test where you have them draw a clock.
Yes.
Tell me what you're looking for in that clock. What can you get out of that?
In the clock, the clock test, it looks at a number of skills. It looks at attention, so you have to pay attention to detail. It looks at planning and organization, because you know that you have 12 numbers. You have to sort of plan ahead and put them in their correct spots. You have to remember or just know where their hands go. You're told a specific time. So it kind of, just puts together a number of those skills, and it taps into them at the same time. So it's a good test to look at to better understand a number of those domains.
Right, and you don't have all day to do it either, right?
No, exactly. It's a quicker test.
Right.
And so the longer neuropsych evaluation may or may not include clock drawing tests, but it also has a number of other tests like list learning and speeded tasks and spatial processing, where you're putting blocks together to make different designs. So similar to clock drawing.
We're talking to Dr. Jessica Barclay of Neuropsychology Associates in Nashville. We got just a couple of minutes left. You mentioned MCI.
Yes.
We talked about that just before we came on. Mild cognitive impairment. What is it, and what are you looking for?
MCI is basically the middleman between normal aging and mild dementia or an emerging dementia. And basically, in order to meet the criteria for a possible or a probable dementia, you have to have cognitive impairment, which the evaluation will answer the question of, and functional impairment, which means you need day-to-day help with things like remembering to take your medicines. Are you leaving the stove on? Are you making mistakes while driving? If somebody has MCI, they have the cognitive impairment, but they're functionally okay. They don't need day-to-day help, and they're independent. And so that can sometimes be a warning sign of an emerging mild dementia. And so, as Dr. Assad said, it's really best to implement treatment for dementia early on in the process, because that's when it's the most effective. So it's really important to catch things earlier on.
So when we start getting functional impairment on top of memory impairment, we're moving out of mild cognitive impairment into dementia.
Yes, and about 15 to 20% of people each year convert or progress into mild dementia. So if you have an MCI diagnosis, it's good to come back a year later and do a reevaluation where you can be your own comparison point, and the person can be monitored and treatment recommendations.
So that sounds like a really important takeaway, right, from your...
Yes, to come back.
Come back and let's do this. Get the insurance to pay for it. Get started a neuropsychological evaluation right away.
Yes.
Get that started.
And I will tell you that a lot of people come back with MCI and either stay there or they progress, and that's just helpful to know.
Right. We're going to put your contact information up. Dr. Barclay, thank you for your time today. And next we'll be discussing therapy. Are there therapies that are specifically available for those with dementia? Find out when we return. Stay with us.